Alright, we are moving on to the next lecture. Most of the focus of this lecture is going to be on the VQ ratio, which is the ventilation to perfusion ratio. VQ. And Q, if you remember from the previous lecture, is the blood flow. I'm actually going to start covering with airway resistance and turbulent and laminar flow, and then we'll spend the rest of the time talking about the VQ ratio and associated pathologies. Okay, so airway resistance is a pretty high yield point because it can get confusing, because if you see R and hear resistance, you think blood flow resistance. But airway resistance is like completely different. Just always have it down here, keep it separate in your mind. It's the flow of air, gaseous molecules compared to blood, which is liquid. And it's very unique in the sense that the mechanisms are a little hard to wrap your mind around, but I think if we make our way through this, hopefully it all makes sense. Okay, so first of all, turbulent versus laminar flow, and these terms also apply to blood flow. Turbulent flow occurs in high resistance areas. Laminar flow occurs in low resistance areas. Turbulent flow, I always think of how high wind can cause eddies, little kind of wind swirls to build up if it's I don't know, in between buildings or something like that. So that's how I think of turbulent airflow. And then laminar is completely smooth airflow, kind of parallel and smooth. As you can imagine, the higher resistance areas will tend to appear at branch points. So anytime there's multiple branching, and they occur, in the case of the lungs, in the conducting zone. So this would be kind of if you look on the graph over here, the trachea, and then you get the bronchi, and then when it hits the medium-sized bronchi, that's kind of a buzzword for this, because the medium-sized bronchi are the point of the airway that has the highest resistance to airflow. Then, as we continue to branch, and I included this picture, you might remember it, as we continue to increase the number of branches, exponentially as we move down the respiratory tree, it reaches a point at the terminal bronchioles where there are so many parallel branches that the cross-sectional area is so high, and there's so many of them, that despite them being so small and having a small radius, and this is where the counterintuitive part plays a role, despite that, there's such a large cross-sectional area and such a large number that it makes up for that, and the resistance actually approaches zero at the terminal bronchioles. And that's good, right? Because we want to have a very low resistance system when we get down near the respiratory zone and the gas exchange area. I think I said all I wanted to say. Okay, so two of the mechanisms for this phenomenon. I kind of talked about this. The further you go down, the more branching you get, and then there's such a large number of terminal bronchioles. And then another reason is, again, with the lungs, you always have an anatomical roll. So when you're inhaling and bringing air in, the airway diameter is always changing, because if you're inflating your lungs, So in a sense, when you inhale, um, the airway generally will increase its radius, and that will allow for um, smaller airway resistance. And um, even though these areas look bigger, you got to remember, these areas, the bronchioles and the terminal bronchioles, there's so much more of them that it's a large cross-sectional area, and all that area is becoming inflated with air and decreasing in resistance as you're taking a breath in. This is just another way to say it. If that first slide didn't make sense, this is important here. It's repeating a lot of what I just said, but just a different way to look at it. Okay, so before we get into the next area, I just wanted to remind you of these normal lab values. It's always good to know normal lab values, especially in regard to anything that involves change in pressure, like pressure gradients. Remember, the big A is alveolar, the small a is the arterial. And, this makes sense in regards to gas exchange again. In the alveoli, the PA, the partial pressure of oxygen is around 100, breathing in all that oxygen from the atmosphere. And in the arteries, or, technically the capillaries where gas exchange is happening, it's around 40. So that's a really large pressure gradient. Whoops. Okay, actually ignore everything I just said. I was looking at that wrong. So this PaO2 is after gas exchange has already taken place, so it's going to be approaching 100, so that makes sense. So when you draw somebody's blood and do the PaO2, it should be 95 to 100. And the difference between these two, remember, is the AA gradient. Ventilation perfusion ratio. Really, really important concept. So basically the ratio of alveolar ventilation. So I always think, how efficiently am I breathing in oxygen to pulmonary blood flow? And this, remember, zone 1, zone 2, zone 3. So that's what determines the Q here. And if you ever get lost, this was always hard for me to wrap my mind around, so I would always just draw out the ratio and think about the math. So, what has to be going up or down for the ratio to go up or down. A normal VQ on average is around 0.8. But obviously the ideal ratio would be 1. It'd be perfect matching of gas exchange, and that's one of the reasons why exercise is so good for you, is that the VQ ratio as you exercise actually approaches near perfect matching of ventilation to perfusion. And there are several regional differences. The biggest one, one of the biggest ones we talked about last lecture, is the Q, or the blood flow. And as you move down, see how there's 2 arrows to represent the changes in Q. The changes in Q, the denominator, are going to be the biggest driving force for the overall change in the ratio. So up here, the VQ ratio is going to be about 3, and down here it's going to be 0.8. And that makes sense that the VQ ratio up here would be higher because, let's draw it over here, because you have a lot of ventilation, right? So the numerator is going to increase in zone 1. It's like the first place the air hits when you're breathing in. And then, if you remember, we talked about earlier, the Q is going to be the lowest of all the zones of the lung. The top of the lung has the lowest pulmonary blood flow because of the gravitational effects. But what's also a little strange here is that gas exchange is actually more efficient in zone 1. And as far as the mechanism of that, I think it's because of the very favorable pressure gradient, because up here you have a higher PO2 and a lower PCO2. So, that's an even higher pressure gradient for O2 to enter the bloodstream, and again, like a higher pressure gradient for CO2 to enter the alveoli to be exhaled out. Another reason, this is just my guess, there's less blood flow up here, right? So maybe it's a situation where this apex, zone 1, is handling less overall work, so it makes it more efficient. But that's just an interesting thing to keep in mind, that despite so much blood flow down here in zone 3, the gas exchange is actually less efficient. What else do I want to say? So this is a good summary table comparing zone 1, the apex, to zone 3. Remember, blood flow is highest in zone 3. That's because of gravity. Ventilation is actually higher as well, but there is a much higher or much more efficient increase in blood flow relative to the increase in ventilation. So just remember, it might be a test question, that blood flow is the major determinant of the VQ ratio. Now, that's the normal situation, but when we get into pathologies, we get into something called ventilation perfusion mismatch. And there's actually, the test you do clinically is actually called a ventilation perfusion scan. So again, this concept always gave me trouble, so I would have to just write it out and think about what's happening. So if we have a situation where V over Q is approaching infinity, it's so high it's approaching infinity, that means that the numerator, in this case the ventilation, has to be super high, and or the denominator or the blood flow would have to be super low. The most common, the most high yield thing you'll see is a massive pulmonary embolus that just completely blocks the pulmonary artery. So in this case, it's completely wasted ventilation. The oxygen that's entering the alveoli is wasted in a sense because the pulmonary artery is completely obstructed. And that's why you'll see these lab values. You'll see a really high O2 level in the alveoli and a CO2 level approaching 0. And that makes sense, right? Because the CO2 is staying in the blood because no gas exchange is occurring. And so when we have a large amount of air that's entering the respiratory tree that is not undergoing gas exchange, do you remember what that's called? It's an increase in dead space. So that's a buzzword for if you see, in step one, they could ask like so many different things about pulmonary embolism, and they love tying it to physiology concepts. So they could ask about this ratio here, what happened to it. They could ask about these lab values, and then they could ask the mechanism, the pathophysiology. It'd be dead space, increase in dead space. So now if we move to a situation where the VQ is high, it's going to be very similar to this previous situation, but it's not going to be complete arterial obstruction. So there might be a pulmonary embolus that's smaller that would cause this ratio to increase, but not to the point where it's approaching infinity. That in real life, I feel like that doesn't really happen. But so there is some wasted ventilation, whereas in this case it was like completely wasted ventilation, right? You can also see a high VQ ratio in emphysema because if this is like a normal alveoli, and then this is like an alveoli and emphysema. Actually, our cadaver first year had emphysema, and we could see this in their lungs. Remember, in emphysema, the elastic tissue support is destroyed, so the alveoli kind of shrinks. So you can imagine as you're breathing in, you might have a lot of oxygen that's not undergoing gas exchange. And also, this alveolar capillary interface where gas exchange occurs is going to be all jacked up. So that's why emphysema can increase the VQ ratio. Now, in a situation where VQ is lower than normal, you've got to kind of like switch your thinking here. So V over Q. So if it's lower, that means the numerator has to be decreasing and or the denominator has to be increasing. So you're going to have wasted perfusion. The blood flow to the lung is going to be okay, but it's going to be passing on by without ever giving up its CO2 to the lungs and without ever getting more oxygen from the lungs. So wasted perfusion. In situations where it'd be low but not quite zero, it could be a situation of low compliance. And that makes sense, right? If your lungs aren't fully filling with air to their best ability, you're going to have a decrease in ventilation. Pulmonary fibrosis, and that's where the interstitial tissue between the alveoli is just like all jacked up with fibrotic like scarring. And so you can imagine as the oxygen enters the alveoli, it's going to have some trouble diffusing across that barrier. Chronic bronchitis can also cause this, asthma, pulmonary edema, etc. So a lot of different stuff. So in regards to the lab values, remember P big A is the alveoli. You're going to have a decrease in the P big A O2 and an increase in the P big A CO2. And if you think about, it's the same rationale as as these pathologies up here, but the situation is just reverse. Gas exchange is very much affected. So the CO2 or the oxygen that would normally have been exchanged with the CO2, isn't happening, right? Now, if we get to a situation where the VQ ratio is so low, it's approaching or it is zero, you have perfusion but no ventilation. So you have completely wasted perfusion. A blood flow, like the good blood flow, was wasted. So this is going to be mostly like an aspiration or a complete airway obstruction, but it can also happen in severe acute respiratory distress syndrome. So if you just think about like the anatomy here, obstruction in the artery up here would mean the perfusion aspect is messed up, wasted, or the good ventilation is wasted. And then the opposite situation, airway obstruction, means the V aspect of the ratio is messed up, and you have like completely good perfusion that's wasted. This is referred to as a shunt. So that's kind of like the pathophys mechanism. It's a shunt, like intrapulmonary shunting. And if you think about it, could also see it as a right to left shunt, because blood's coming from the right heart to get oxygenated, but there's no ventilation, so it's never getting oxygenated, so it's returning back to the left heart as, in the same state as deoxygenated blood. And these are the characteristic lab values. The Wikipedia read on this is pretty short, and it can be a confusing topic, so there's the link for that if you need it. And so these pictures are just different ways of saying the same thing. Try to include multiple figures. Sometimes it helps to visualize what's going on. So remember, this is like airway blockage. So that would cause a right to left shunt and a VQ approaching zero. Here is a artery blockage, like a pulmonary embolus, and that would cause a increase in dead space and the VQ ratio to approach infinity. And so in the case of like the shunting problem, but the right to left shunt, the P small a O2 is going to be pretty much the same as the pulmonary artery PaO2 levels. So that's the deoxygenated blood that's leaving the heart. And that makes sense, because as you're exiting the other end of the alveoli, no gas exchange has occurred, you're going to have almost the exact same lab values. Okay, let's do some practice questions. So the distribution of ventilation within the lung is influenced by regional variations in lung inflation. That sounds good. Regional variations in airway resistance. That's definitely true, right? Because we talked about that. Regional variations in lung compliance. That's also true. And then I'm not sure the mechanism of collateral ventilation, but regardless, all these are true. So the answer is all of the above. Okay, which of the following could potentially result in more low VQ regions within the lung? So I included this part of the previous slide. You're going to have some wasted perfusion. So you're already thinking that something is going to affect the ventilation aspect. Obstructing arteries is going to affect perfusion, not ventilation. Doubling the ventilation definitely would not decrease the ratio. Vasoconstriction of the arteries would affect perfusion, but atelectasis, and all atelectasis just means like collapsed lung. That will definitely decrease ventilation, which would decrease the ratio. Okay, which of the following statements is correct? Right to left shunts represent an extremely high VQ ratio. No, it's actually low, or 0. Right to left shunts are not a cause of elevated AA gradient, so that's wrong because they are a cause. An increase in the dead space can result in an increase in the number of high VQ units in the lung. So this is true. This would be, so remember, an increase in dead space. That means there's air that's entering, oxygen that's entering the respiratory tree that is not undergoing gas exchange when it normally should be. So that results in a high VQ ratio. D, let's see, curve, that means low. I'm just not going to attack that one. And this is just a review of a high ratio. The ventilation is going to be wasted. So increase V, and you have an increase in the physiologic dead space. Remember the VD. Okay, so just a quick review of stuff we covered. I'm not sure when it was. Like one of the first 2 lectures. So list all the obstructive and restrictive lung diseases you can think of. So I'd encourage you to take a minute, pause it, and then list everything that comes to mind. All right, so obstructive, there's really only 4 big ones that you need to think of. There's chronic bronchitis, there's emphysema, bronchiectasis, and asthma. Then there is a lot of restrictive lung diseases. So if you can think of those 4 for obstructive, and then remember, everything else is restrictive. I just want to show you all the examples of restrictive lung disease. So pneumonia, TB, sarcoidosis, idiopathic pulmonary fibrosis, interstitial lung disease, cancers, rheumatoid arthritis, lupus, acute respiratory distress syndrome, and also respiratory distress syndrome of the newborn. And then there are extrinsic causes like any neuromuscular disease, well not any, but a lot of the ones we think of like ALS, MS, muscular dystrophy, they can all cause restricted patterns on spirometry. Scoliosis, obesity, something called obesity hypoventilation syndrome that causes a restricted pattern. That's just where you're literally so fat that there's no more room for your stomach to expand, so it just goes up and like crushes the lungs. Myasthenia gravis. So point is, there's a lot of things that can cause restrictive disease. It's grouped into intrinsic causes and then extrinsic causes. Okay, sorry that was a little bit longer, but the VQ ratios are always annoying.